Assalamu alaikum. Thank you for joining. We've got some attendees both on Zoom and on YouTube, and we're going to give another couple of minutes for more people to be able to join before we start. Jazakallah khair. Assalamu alaikum. So we're going to get started with today's online lecture. Jazakallah khair for joining. I can see we have people joined both on YouTube and on Zoom. If you've joined on YouTube, then please feel free to message in the chat for YouTube. I'll be monitoring that. And then I'll message, you can also use the chat function in the webinar if you've got any questions, or you can use the Q&A function. You can also raise your hand if you've got a question, and we welcome any interactions that you want to make. So I'll start by introducing our speaker for today. We're very honored to have Dr. Munir Ravalia. Munir has specialized his focus in dentistry on conscious sedation and medical clinical hypnotherapy. He earned his dental degree from the Royal London Hospital in 2002 and furthered his expertise as a senior house officer in oral and maxillofacial surgery. Throughout his professional journey, he achieved the prestigious membership of the faculty of the Royal College of Dental Surgeons, England. His professional experience spans primary and secondary care, leading him to King's College Hospital, where he served as a specialty doctor in acute dental care. Presently, he holds the role of trust dentist and clinical lecturer in conscious sedation at the Royal London Hospital, where he leads a specialized service for highly phobic and anxious patients with a group of consultant psychologists. He has acquired additional skills, including training in acupuncture for the head and neck region and attainment of a medical diploma in clinical hypnosis. He has set up a training academy for fellow clinicians who wish to learn further the role of clinical hypnotherapy in the management of dental anxiety and pain management. He is on the editorial board of SARD and on the council of ADAS. These are both associations of dental sedationists, and ADAS includes anaesthetists as well. Thank you very much. I'll now hand over to Dr. Munir.
Assalamu alaikum. If you can just allow me to share my screen again, that would be great, inshallah.
It is currently sharing and it's streaming on YouTube as well.
Okay, it says my screening is paused.
Okay, it might be there's a time delay on YouTube. Let me quickly check.
Can you see this now?
I can see it on Zoom. Maybe
okay,
the attendees, if you can put it in chat.
Yeah, maybe if they can just let me know that they're getting this first slide.
So there should be a reactions button. If anybody wants to just give us a thumbs
I'm just
up,
gonna have a look. I can see your first slide. Just change slide.
Yeah, so if you just change your slide, we can all see your title screen.
Okay. The next one works?
Yep.
Okay, fine. Okay, Bismillah ar-Rahman ar-Rahim. So, inshallah, I appreciate we're presenting this to maybe colleagues in Afghanistan who may not fully understand my English. So, it may be worthwhile every few segments of the presentation, if there's any Afghan dentists that are proficient in English that would like to assist me to translate. But if you feel that's not relevant and you're understanding what I'm saying, then again, just put something in the chat so we can kind of see how people wish to proceed, inshallah. It'll be about 45 minutes. There'll be some time for questions. So the primary aim, I feel, of achieving proficient local anesthesia and pain management, it's really the cornerstone of good dental care, because we know to be able to carry out most dental procedures, our patients should be ultimately numb. And there are multiple factors why anesthesia may work, may not work. A lot of them psychological, some of them pharmacological, to do with different patient aspects. But I want to sort of go through some of the basic techniques and then show you some of the advanced techniques that we utilize. I utilize in general practice, but also with my specialist consultants in the Department of Special Care at the Royal London Hospital, inshallah. So just moving on from this first slide. Some of the aims for today is to look at understanding the various local anesthesia techniques, but not only that, looking at non-pharmacological based, for example, distraction techniques, and then looking at the use of preemptive and post-operative analgesics that can assist actually the anesthesia that we give in dentistry. And this is a picture of a patient who's a special care patient, dementia patient, on the right-hand side that I treated with my colleague, Dr. Hamza. You can see the patient is having some intravenous medicaments placed through the antecubital fossa. And then we're going to look at some more advanced anxiety management techniques, as well as using things like intravenous inhalation, sedation, and also how analgesia can be utilized to assist. Many of our patients, as we know, attend because they are ultimately in pain. They may have infection. So we can use various armamentarium to assist us. And if there are any questions as we go along, I don't mind people typing in. It's better, I feel, to go through things as we go along. And you can also write on the web chat, and we can discuss those further, inshallah. Jazakallah khair. So one of the main elements of assisting us giving anesthesia is topical anesthetics. Now these come in various forms, and you can see here I've put a various number of different topical anesthetics, but some of the pitfalls. So a lot of times we see colleagues using either a gel or a liquid topical anesthetic, such as lignocaine, which I feel is the weakest of agents, because I feel it's not left on the mucosa to give soft tissue anesthesia for a sufficient time. And therefore, this leads to not having its deliverance and in an actual manner that benefits the patient. So sometimes it's a placebo, and therefore may not have any clinical efficiency. What I find is this picture in the middle called Hurricane. There are various ones. There are Maxocaine. You can see in America there's something called Dr. Numb. A lot of these have lignocaine, but the one that I prefer to use is using benzocaine. Benzocaine 20% is a much higher concentration, a much stronger anesthetic, but it must be left on the mucosa for a minimum of 30 seconds. If you put it on too quickly, if you put on too much, it can also give the patient a bit of a gag because they swallow it, they become uncomfortable. Most anesthetics, whether they're topical or even the lignocaine or articaine or the different anesthetics we use in the injections, they can leak from the area and give this sort of foul taste that many patients experience. So you have to leave it on proficiently, sufficiently enough to get soft tissue anesthesia. And this is, of course, the aim is to allow us then to be able to give the local anesthetic via the needle. And I'll show you various contraptions, various sizes, and the reasons why we do that. But this really does assist, and I find especially in pediatric patients or very highly nervous patients, if we can give very proficient topical anesthesia, then when we give the local anesthetic through the needle, they feel very little pain. And this, of course, leads to a much greater outcome because we know a patient who's nervous, a patient who's in pain, a patient maybe having more advanced surgical procedures, maybe root canal treatments, apicectomies, dental clearances, complex dental oral surgery, impacted wisdom teeth. If we can make that initial pain control experience very comfortable for the patient, it then allows that patient's mind to go to what I call a nice place, a calm place, so that when we introduce the local anesthesia, then inshallah we'll be able to provide that in a much more proficient way because we know the mind-body interaction is very, very jointed. There's no disjointing in that. And therefore, if whatever we can do to assist them will inshallah make the experience better for our patients. And ultimately, no clinician wants to be drilling a tooth or extracting a tooth when the patient's uncomfortable, because that, of course, then affects us as clinicians because we feel that our patients are in discomfort and affects us as well. So inshallah, there are various types, but I feel something like benzocaine in whatever form, it's a gel, it's a liquid, doesn't really matter. It's quite a useful way of assisting in this initial process of getting soft tissue anesthesia. Now, what are sort of the basics of giving dental anesthesia? I know in various countries and sometimes in A&E units, they may not have all of this, and they sometimes draw up local anesthesia. It could be plain lignocaine with a very wide bore needle. And this is very tender and painful when we introduce this into the mucosa for whichever technique we want to use, whether that's dental infiltration, whether that's going to be a block technique. So if we look here, we can see various types of anesthesia. The most obvious one being xylocaine, which is a lignocaine-based anesthetic in an ampule. We have then again articaine, which is very globally used type of anesthetic. It's being used more and more and more, so we don't have to give more complex blocks, and can be used as an infiltration or intraligamentary or intrapulpally to assist. For example, if someone has a very infected or inflamed root canal system, it's very useful. So if we look on the bottom right, this local anesthetic syringe, there are various types. This is just an example of one. It has the front area where the needle attaches, the harpoon where the anesthetic is basically pushed by the clinician, and it has a good finger grip, so we can hold this carefully. And obviously, that one of the aims is not to slip with your local anesthetic, because that can cause trauma and, of course, cause further pain to our dentists. Now, there are what we call short and long needles. In the crux of it, the basics of this, my honest opinion, is as long as you can get the local in with a very, very fine bore needle. So dental anesthetics, out of anesthetics anywhere in the body, because local anesthesia, like lignocaine, is used all over the body for local anesthesia. Let me just see. Someone's asked, why is not picture? Salam, can you use a screen, or are you having problems?
Don't worry, I'm reading the chat and just responding. There's one particular
Okay,
user who's having some technical
fine.
difficulty.
So I don't need to read it. Shall I leave that with
don't
you?
worry. I will alert you if there's a question.
Fine,
I
fine.
think that I don't know if anybody else is having any issues, but this particular user might be having difficulty seeing your screen.
Okay.
So while we've disturbed you anyway, I might as well continue. But on the iPhone, sometimes the screen that you're sharing doesn't show automatically, especially if you swipe right or swipe left. So that might be the issue for the person who's trying to message.
No problem.
Okay, but let's continue. I don't see any other questions at the moment.
Okay. So in reality, the smallest bore needle is required. And some people will say that using the long needle is good for doing, for example, an inferior dental block, a high acinosis block as well. This is a high block for the trigeminal nerve. But ultimately, we want to dispense the local anesthetic closely to the site of surgery, or to basically where the area we want to numb up the tooth and the soft tissues. And ultimately, this soaks in and gives anesthesia to the bone area as well. And we understand and we know from anatomy that the maxilla has a much porous bone, as opposed to the mandible, the lower jaw, which a lot of times does need a block, but supplementary use of techniques I'll show you is very useful to gain anesthesia, especially in infected areas where we might describe the hot pulp, the pulp that is infected, hyperemic bleeding, the nerve is either dead or dying. So the ultimate aim is to use a very, very small bore needle to create the least amount of pain to the patient when we give the anesthetic. Now, there are, of course, more advanced techniques. So, for example, the wand on the top left is an electronic device, and it dispenses the local anesthetic in smaller quantities, in a much smaller speed. And we know that giving anesthetic very slowly allows for less pain. And there are multiple systems. There's even something on the bottom left, which is a quick sleeper. It's an electronic device that connects to a foot pedal, and you can adjust the speed at which anesthetic is given. And there are multiple ones you can see if you go online and look globally. There are very expensive, very neat dispensing units to give the local anesthesia. Again, we know that if we vibrate the area, whether that's manually with our finger, using the end of the mirror, or using something like the Vibrajet on the right-hand side, which is a very interesting instrument. It shakes the anesthetic as it gives it. It sort of affects the C and delta fibers for pain in a different way, and again reduces the pain of entry once the anesthetic needle is in place. But these are more advanced techniques, and of course they can potentially come off this lecture the actual use of these systems, but I'm not going to go into them in detail. But it's very important I feel, for us to know about these, because they are very useful, and being used globally and widely, and could enhance the delivery of local anesthesia. Now, if we were to look at local infiltrations, the basic premise is that it involves disposing or depositing the anesthetic solution, whichever one we decide, directly into the tissues to numb the specific area. And of course, this is crucial for localized pain control in dentistry. So we can see here this example of the maxilla, the anterior maxilla. You could do an infraorbital nerve block. Can be quite tender. It's not used often in dentistry, I must say. We don't use it a lot, but it can be used. And if you go from this, we have the field block, which then numbs up that whole field. So one anesthetic in an area can numb up, for example, the anterior. You can numb up the upper 1, 2, 3, 4 region just with one local anesthetic. And of course, then infiltrating specifically for a tooth or teeth that need to be numbed. So we can do nerve blocks, we can do field blocks, and we can do infiltrations. So we're going to look at these different types of ways of giving local anesthesia to achieve the correct anesthesia in the correct anatomical position for our patients. Now, a supraperiosteal injection, you can see on the right-hand side, we're using a very simple delivery method, like a cotton bud, a sterile cotton bud, to apply the topical anesthetic that we mentioned. As I say, I prefer the benzocaine 20%, but you must leave it on the area for sufficient time. And benzocaine, because it's much stronger, can be left for much less time, 30 to 40 seconds, specifically exactly where you want the local anesthetic to go. We retract the lip, and then we insert the needle at the mucobuccal fold. The reason we enter it there is because it's the point of least resistance, and it's the point of least pain. And if you can see, the dentist here is making the area quite nice and taut as well, because this again stimulates the different delta fibers for, well, basically before the entry of the local anesthesia. And we deposit several mils of anesthetic to give very good profound soft tissue anesthesia. And we have to aspirate with the injections that we use. They are self-aspirating. There's more chance if it's a wide-bore needle and a non-aspirating syringe for the anesthetic to be deposited within the vein or an artery. And this wouldn't be beneficial for the patient because it causes quite profound tachycardia. The patient can feel quite unwell. And of course, it enters the systemic blood system very quickly and can have other issues, fainting, patients feeling quite unwell, or they say the anesthetic is having like an allergic reaction to it. They're truly not. It's just the deposition of the anesthetic is not in the correct position. Now, of course, we use single-use needles for the patient. Of course, one needle can be used in multiple sites of that patient, but we would, of course, never use that for cross-infection control procedures and safety of our patients, so they don't get any blood-borne diseases which can be transferred from such a needle. So we deposit. Yep.
Dr. Munir, sorry, I just wanted to jump in with a question here. You
Yeah.
mentioned aspirating needles. Can you
Okay.
explain for the people who might not have heard that term before what aspirating means?
Yeah, sure.
And why it's so important?
Sure. So generally, if we were to draw up anesthetic in a normal, let's say a 10 ml syringe, that when you put saline in to wash the mouth after surgery, if we draw a pure lignocaine or whatever anesthetic solution into that wide-bore needle and syringe, when we introduce it, it's impossible to see whether the anesthetic has gone into the small peripheral vasculature or whether it's actually gone into an artery or vein. With a self-aspirating syringe, you get some sort of, when you press the needle, it retracts by a millimeter or two, and this then allows us to see if there's any blood that comes back into the system. So this is known as a self-aspirating, and therefore we can be more confident to show that, to sort of prove to ourselves and then for the ultimate safety of the patient, to ensure that the anesthetic is being deposited locally as opposed to being deposited into a vein or an artery, which is not ideal for two reasons. Like I said, one, it makes the patient feel very uncomfortable. They get tachycardia. It goes into the peripheral vascular system as opposed to the local system, and therefore the anesthetic is almost washed away and doesn't really have any profound effect for anesthesia in the dental area. Okay, so using something like a self-aspirating syringe that I showed at the beginning, I can show that again later, then it's very important to use something like that for ultimately patient safety and, of course, for the efficacy of the anesthetic to be able to work. So like I said before, single-use needles, we can either deposit the anesthetic by the main nerve trunk. This would be a block. For example, you could do a mental block. You could do an inferior dental block, an inferior orbital block. As I say, not used a lot, but can be used. And then, of course, depositing the anesthetic, infiltrating it near the terminal nerve endings. And this is a very powerful technique, especially in the maxilla, but we use it in the anterior mandible. And it can also be used to supplement the block in the posterior mandible to get soft tissue anesthesia, get lingual anesthesia, buccal anesthesia, and can be used in combination with such techniques. So we're talking about a supraperiosteal, above the bone, basically above the periosteum, and we can use periodontal ligament techniques. So this is injecting, I'll show you a bit later, the anesthetic into the periodontal ligament, useful in teeth that are maybe not getting numb or infected. Intraligamental is useful, and of course, especially for our endodontists. But even if you're doing an extraction and the patient just isn't getting numb, they may need to have the cavity, the tooth opened, because the tooth may be very hyperemic, very infected, and we can use an intrapulpal injection using the same needle we have, the same anesthetic we have, but at a very high pressure, and that pressure pushes the anesthesia physically into the pulpal system to gain the relevant anesthesia that we require.
Assalamualaikum. Dr. Munir, I'm just going to ask another question at this point,
Yeah.
because that has always been my scariest thing to do. I've had really bad effects sometimes when I've tried interpulpal, where
Okay.
especially the children, they just cry a lot, and
Yeah.
I don't know, is there how do you choose the right teeth to do it on? How do you know when it's going to work, when it's not going to work? And is there a technique or anything to make it more predictable?
I think definitely it can be used in pediatrics and adults. Of course, you need to warn the patient. An intrapulpal injection can be tender. It can be painful. The indications would be if after you've given for example, your block anesthetic, for example, an inferior dental block, you've given your intraligamental block, periodontal ligament block, and if these are still not working, then we would look at giving an intrapulpal block, but under pressure. So it has to be under pressure. If you're not doing it under pressure and the patient doesn't feel any pain at that time, it probably means the anesthetic isn't being deposited in the right position. Now, it is painful. So we do warn our patients that there will be a moment of time that we're going to be putting the anesthetic under pressure, specifically into the nerve, to get the nerve numb. And if they can understand the reason behind it, it makes it much easier. I can appreciate in children, this can be much more complex. There are techniques sometimes of soaking anesthetic on a cotton wool pledget, like a little small bit of cotton wool. And sometimes we do this in cases where it's just so tender, we place the anesthetic on the cotton and place it into the hyperemic pulp. And I know some endodontists are fond of using saline to actually wash and reduce the hyperemic, the blood flow from the area. So we're not washing out the anesthetic, because obviously if we put it in an area where there's lots of bleeding, it just washes out. So saline is very useful before we even use the anesthetic. It just dries the field, keeps it clean, and then we can utilize the intrapulpal technique. But as I stress, you have to let the patient know there will be a moment of pain or moments of pain, but make them understand the reason for this is to basically get them numb if they're not getting numb. But before I go to that, one of the failures I see, and this is irrespective of someone who's a first-year dental school undergraduate and someone who's been doing dentistry for 40 years. Unfortunately, if we do not leave the local anesthetic for a sufficient amount of time to get full pulp and anesthesia, and this is coming from Malamed. So Malamed is an American professor of local anesthetic. He's sort of known as the professor globally in anesthesia. And if you read his book, and I'm more than happy to share his book with our colleagues here, it's a very comprehensive book. He says that to get full pulpal anesthesia, whether that's through a block or through an infiltration, you have to wait between 10 to 18 minutes. And what happens a lot of times is we give the inferior dental block, as an example, we give a block, and people wait 2 to 3 minutes, because 10 to 18 minutes is a relatively long time. Imagine just giving someone injection and just sitting there for 10 minutes, okay? Now, if you don't leave it for that time, what happens is you get a lot of soft tissue anesthesia. So when we then use our probe, for example, or whatever method we want to test, we press around the gum, we press around the tooth, and we say, oh, the patient's numb. Then the minute we pick up the drill, the minute we pick up the forceps to extract the tooth, the patient's jumping in the chair, excruciating pain. It's because we haven't waited between 10 to 18 minutes. He actually says 18 minutes is the minimum time to get full pulpal anesthesia. So we may get soft tissue anesthesia, but not pulpal anesthesia. So I always do, my aim, and it's, of course, if someone's working maybe in a busy hospital oral surgery unit, multiple patients, what you can do is give the patient the anesthetic and tell them to wait outside for 20 minutes to half an hour. And this then allows the anesthetic to take effect, to reach the porosity of the bone. We know it's much less porous in the maxilla, so it's easier. Mandible much more harder. But if we don't wait enough time, I feel a high rate of failure is because of this. And what happens is we give the ID block, we wait 2 minutes, we wait 3 minutes, the patient starts getting some soft tissue anesthesia, and we start the dental treatment. They're in pain, so we give another block. We wait another 2-3 minutes, they're in pain, we give another block. What's actually happening here is it's not the third or fourth block that you're giving taking effect. It's by then you waited 20 minutes because you've given all these blocks or infiltrations, and it's actually the first one kicking in. So if we wait enough time, it generally means we don't need to give 2 to 3 blocks. Now, of course, there are variations in anatomy, but generally in dentistry, we're quite blessed in the sense that a lot of anesthesia we give, even if we're not in the exact correct position, the anesthetic solution will infiltrate and spread to where it's needed. It just needs time. So please remember, when you give anesthetic, wait enough time. Wait 10 minutes, wait 15 minutes, up to 18 minutes to get full pulpal anesthesia, because there's no point getting soft tissue anesthesia, which is what we get, which is what we look for, and then the patient's in pain. Is that making sense? Fine, I'll continue.
Yes, it is. Jazakallah khair.
So this is just some examples of, there are, various terms we can see here. And I don't think we need to get caught up too much in it. Is it a posterior, superior alveolar nerve block? Which teeth are going to be anesthetized? The basic principle is aim for the area where the tooth is if you're infiltrating. And as you can see in the bottom picture, this anesthetic that's being deposited in that mucobuccal fold, it's much less tender. Place the anesthetic in. I would wait about 5 to 6 minutes for this. This will then give some profound soft tissue anesthesia. It doesn't mean we've still got pulpal anesthesia, because even if we test, the soft tissue might be numb. And then that anesthetic will spread round. So for example, this picture here in the bottom in this center, just between the upper right 3 and 4 area, that will generally tend to numb the 3, 4, 5 area, and maybe some of the upper right too. Then if we decide that the tooth is still, if the patient is still feeling sensation, then we can either top up the anesthesia here, because this is a supraperiosteal, or we can then go for a subperiosteal injection. So this is going under the periosteum, because then it will hit bone and infiltrate around there and soak through the bone. That's the whole point of it. And then we will get much more profound pulpal anesthesia. And of course, then following the relevant time scales and following the relevant protocols, if we then need to give supplemental intraligamentary or intrapulpal, those can be done with much more effect. And we can see again on the top left-hand side, there's periodontal ligament injection into the periodontal ligament, because this patient maybe had a hot pulp, a broken tooth, caries, which is deep into the pulp. So the principle is depositing the local anesthetic into the area off where we want to numb. So obviously this is the mucobuccal fold, the maxillary tuberosity, and of course using the different size needles for, depending on how far we want to deposit the anesthetic. Is it just a simple infiltration, or are we aiming for a block? We may use a longer needle. Again, anteriorly, this shows the anterior superior alveolar or infraorbital nerve block. Again, depositing the anesthesia. You can see on the left-hand side the yellow aspect of the maxilla, and it numbs. It gives sufficient soft tissue anesthesia to several teeth where you deposited. Again, waiting sufficient time, 10 to 15 minutes. If the patient is still then in pain, then we know that we need to give supplemental anesthetic as described, the periodontal ligament or the intrapulpal. But these are very profound ways of getting soft tissue anesthesia. So each time we then even aim to give, for example, the periodontal ligament injection, the pain is significantly reduced for our patients. Now, the palatal tissue is probably the most tender, most painful area that we can give anesthesia in the whole of the mouth. So there are various ways of doing this. Topical anesthesia, I feel, doesn't work as profound, but there are techniques we can use to stimulate the area before we give the anesthetic. So, for example, on the left-hand side, someone's using a cotton bud. By pressing, you can see this blanching of the area. This is before the anesthetic's been deposited. And that blanching is showing a reduction in blood flow, which again reduces the innervation temporarily through pressure to allow us to give the palatal injection with much less pain. In the middle, there's a picture of a very fancy device where you can, it has a little circular slot where you're aiming to give the anesthesia. And again, you press this area for about 20 to 30 seconds to get this blanching. And I find it works very, very proficiently. If you don't have any of these, it's very simple. Use the dental mirror, and this is what I use often. We can turn the dental mirror upside down, so we're not using the mirror end, but the handle end, and press the handle end on the pellet, again, for 20 to 30 seconds, get blanching, and just before you're about to introduce the palatal injection, press very, very hard, because it starts to stimulate those pain fibers already, so the patient feels something, but they don't feel pain. And then when you introduce the palatal injection for whichever teeth you're numbing up, the patient feels a significantly reduced pain, which ultimately is very, very useful, because that patient then has confidence in you as a clinician. And one of the things they showed, a reason why a patient would return back to a dentist is because if they can give the least painful injections. That's one of the most. They did a study in the British Dental Journal, and this is quite well known globally. If your ability to give local anesthesia proficiently, sufficiently, and without pain, that patient is yours for life, because they may not have experienced this before, they may have experienced pain before, and of course, if you can give this and make them comfortable, it's sort of what they call a practice builder. So very, very useful to learn these techniques from day one ready, from dental school, if you can get into these good habits. But there's nothing wrong with us changing. As I say, I teach this technique to consultant prosthodontists, consultant oral surgeons who've never done this in their life. And so it's a very powerful technique. And once they start using it, they'll say, I don't know why I never used this. It's not rocket science, but it's a game changer. So always try and do this. Let the soft tissue become blanched, and you'll find the entry of the needle, this very fine-bore needle, will cause the patient almost zero to no pain at all. It's a very powerful technique. Now, Going into blocks, I'm not going to go into blocks too much here, but we know the deposition of the anesthetic in the correct position anesthetizes from a lower anterior, ID block. It anesthetizes the incisive area, the mental areas. You can give lingual. Of course, we can't just give a block and not anesthetize the lingual area. You can do it simultaneously by swinging the needle more lingually as you pull the needle out and deposit the anesthesia. But you generally get more profound anesthesia in this technique for the lower posterior molars. For the premolars, then we're looking at giving a mental block, and anteriorly we can use the block, but we can also use infiltration and intraligamental as needed, if the patient is has any source of infection. And of course, the lingual will numb up the inferior portion of the anterior 2/3 of the tongue. So again, very important to not only numb up the pulp, but sufficient soft tissue, especially if you're putting a rubber dam on that can be tender lingually. If you're extracting a tooth, then of course we need good and profound soft tissue anesthesia, as well as the relevant pulpal anesthesia for that tooth. Now, this is an example of what we call a hot pulp, and you can see the anesthetic solution from the needle being deposited right into the pulp. So whichever, sometimes it can just be one nerve branch, an upper molar, lower molar, multiple roots, multiple nerves. And like I say, you must let the patient know that there will be some pain, but the whole point of this is to get the anesthetic into the nerve system so ultimately they feel no pain. You must let them know, and it has to be done under pressure. If you do it very lightly, all you're doing is just filling the cavity, the pulp chamber with the anesthetic, and it doesn't really deeply soak in into the to the actual root canal system. So it's under high pressure. The patient will feel some discomfort, but warn them preoperatively before you do this, and then they won't have a shock. They'll understand that there is something coming up. They'll be prepared for it, and it's a very powerful way. And I know endodontists are the masters of this. So we may even have a lecture in the future by one of our specialist endodontists who deal with infected and what we call the hot pulp, but a very powerful technique to be used in conjunction with the other techniques that we have mentioned as well. Now,
And Dr. Mir, I'm
yes,
sorry, I'm just going to ask another question here.
yeah,
About hot pulp. So these are teeth that are really painful for the patient, even though you've already given your usual anesthetic.
yeah,
If for any reason you weren't able to use the intrapulpal injection,
yeah.
what kinds of medicines or materials can be used for a hot pulp, and which ones are good, how do they work, and which ones are bad and that should be avoided?
So are you talking about medicaments to put into the canal system and leave
Yeah,
for a while?
so I know that when I was in Afghanistan, I
Yeah,
visited a mobile clinic which was out in a village, Bule Charkhi, and I was looking through the cupboards because I was looking for some filling materials, and
yeah.
I found some former Cresol and
Okay.
formaldehyde-based products.
Yeah,
So I haven't been able to speak to any of the dentists, and I know that used to be a technique in the old, not the old days, sorry, like about 20 or 30 years ago in the UK, and then it got banned.
yeah,
I'm not sure, what else might be used. Some people might use a different technique which has fallen out of favor, like arsenic. Can you comment on some of the techniques that we don't use anymore and
yeah.
why, and what other
Yeah.
medicines there might be?
I think the former creasel technique was used quite significantly, and I used to use it with a lot of success in the past, and that was basically putting the former creasel directly into the pulpal area, and you basically have to leave it. So it may not mean that you're able to carry out the dental procedure there and then, but by applying it to the area, it basically kills the nerve. So this hot pulpitic tissue becomes dead in an essence. And obviously, if our colleagues still are using that and able to use that, it is a very powerful technique. But as you noted, it's sort of been stopped in the UK for many years. There are other techniques of using things like lead mix, which has some sort of not only anesthetic, but it has a anti-inflammatory in it. It has some dexamethasone in it. And what this does is that it basically reduces the inflammatory response in the area, but you have to then leave that on the pulp for a significant period of time, meaning a minimum a day or a couple of days. So that pulp then becomes, in essence, killed for you to then to be able to go back to anesthetize the nerve. But I find a lot of times, if you've given the block, you've given the infiltration, you waited sufficient time, and if it's a very hot pulp, washing it with saline reduces the blood flow, and then using this intraligamental technique, I think is one of the most powerful techniques. But you can also soak local anesthesia on a cotton pledget and leave it within the pulpal system, and then putting a temporary dressing over the tooth to allow that tooth to settle down so it's no longer a hot pulp. So when you come back into it successively, whether that's after 48 hours, 72 hours, or a little bit longer, depending if the patient also needed antibiotics for a more systemic infection. But I'm going to go through some analgesic techniques that we use preoperatively and postoperatively that we can get the patients to either take at home, or we can give them in the surgery before we even start our local anesthetic procedure. And if there's anything else you want to add to this at this point, I'm more than happy for you to give some of your experience, because you're obviously dealing with a lot of kids that maybe have quite severe hot pulps.
No, so you've mentioned them all, and I think the main thing that we use is something like Ledimix, or there are other brands, but the essential thing is that the ingredients have steroid in, which calm down the tooth, but also a bit of antibiotics with mixed into that same mix. So it's disinfecting and decreasing the bacterial load, which is the amount of bacteria inside the tooth.
Yeah, and ultimately you sometimes do have to leave that for a couple of days for the nerve to settle, and then you sort of re-enter the tooth to be able to conduct whatever dental treatment is needed. Because intrapulpal is not only used for root canal, it sometimes has to be used for if the nerve's so inflamed that the patient's in excruciating pain while you're trying to extract the tooth due to infection, and with the concomitant use of systemic antibiotics as required. Moving on for this, I want to just sort of talk to our colleagues who may be not aware, or those who are doing more advanced surgery, that there is obviously a great role of conscious sedation as opposed to general anesthetic, which we know is by an anesthetist basically making that patient unconscious and a machine breathing for them, keeping them alive. But I feel in more and more in oral surgery, implant provision, but even in general dental care with people who are nervous, there are some conditions that some patients find that they just don't get numb, something called Ehlers-Danlos syndrome. I find a lot of patients, they just don't get numb. They metabolize the anesthetic very quickly. And therefore, using a technique like conscious sedation, which I'm going to go into, really enhances the patient's comfort, reduces the anxiety. Of course, if someone's in pain when you're doing dentistry, we see a lot of our older patients who've maybe had a traumatic incident as a child are then left anxious, nervous, phobic, and don't go back to the dentist until, unfortunately, they have severe acute pain or acute facial infections. And at that time, they're already in pain. And you may need to give them more pain to get them out of pain. But therefore, using a procedure like conscious sedation really facilitates and enhances the patient care. So this is what I do a lot of, and I know some of my colleagues on here also use. So for the most simple thing being an oral sedative, we know in England, a lot of people call it a Valium. It's a diazepam. It's a benzodiazepine. There are various different forms in America where they use a lot of razepam. It basically makes the patient feel a bit drowsy, and it's not truly an analgesic. We know that it's a sedative, but again, that sometimes just takes the edge of it for the patient. So when you are giving the anesthetic in whatever form or way you feel is the best for that tooth or teeth, it just makes the patient feel much lighter, much calmer. Moving on from that, nitrous oxide sedation relative analgesia, inhalation sedation. It's a very potent analgesic, and that's why it's also called relative analgesia, because it does give profound analgesia working in the brain centers in conjunction with obviously your local anesthetic. You can't just give inhalation sedation and not give a local anesthetic. That would be completely counterproductive because the patient would be in pain. But it's found to really assist in patients who've got either low pain threshold or anxious, already heightened state of awareness. They feel much more pain. It's quite a well-known phenomenon. Can be used very powerfully, very safely in dental surgeries. It doesn't have to only be done in hospital setting. It's very safe, used all the time globally, and can assist, of course, even our pediatric patients maybe having simple restorations just to take the edge off their fear. Moving on, using intravenous sedation. So this is placing a cannula to allow intravenous medicaments to be placed, not only by an anesthesiologist. We use this globally as dentists as well in the UK. A lot of us, myself, I know some of our colleagues in the special care departments, they use the intravenous sedation. And through that, not only can we give sedatives, but we can give very, very good doses of opioid analgesics, which again can be useful in what we call these hot pulps in oral surgical procedures, very complex wisdom teeth removal, impacted teeth, more complex maybe maxillofacial surgery. Apart from having general anesthesia, intravenous sedation can be utilized. So combination can be used. If someone's very nervous of cannulation, we can give them oral sedative. We can sometimes give them nitrous oxide to even allow cannulation. That can be then removed, and once we've given the cannulation, we can give the relevant intravenous medicaments, which I'm going to show you and give examples now. So of course, in oral surgery, this is a case I was doing with an oral surgeon. It gives the patient comfort, as we say, because we can give the sedatives to minimize discomfort, relax the patients, very profound anxiety, anxiolysis, making the experience comfortable for the patient. And of course, some of the sedatives we use, like midazolam, which is a benzodiazepine, gives amnesia. And some patients would prefer not to remember what they may deem as a traumatic dental procedure. But also some dental procedures can be quite traumatic. You know, severely impacted horizontal wisdom tooth sitting near the inferior dental canal can be quite painful. So utilizing intravenous medicaments, sedatives, analgesics, opioids facilitates the procedure and really assists the surgeon as well, because obviously if the patient's constantly moving in pain and you're topping up anesthetic after anesthetic after anesthetic, we know this can be, sort of a bit off-putting for the clinician as well. So it makes the dentist experience, not only the patients, much more comfortable and conducive to giving the relevant dental care that they need. So preoperative analgesia, it's shown by giving preoperative analgesia, and I use this quite a lot, I'll be honest with you, in patients who've maybe been referred, who don't get numb, who have a hot pulp that needs root canal or a tooth that needs extraction with infection. We can give analgesics before the surgery. So usually we recommend at least an hour before if it's oral. Of course, if things are given intravenously, they don't pass the body system. So first pass metabolism. You have what we call 100% bioavailability if it's given intravenously, as opposed to 25 to 30% of the analgesic only working, because the body looks at it as a foreign body and breaks it down in the kidneys and liver. So we can give dexamethasone to help with reduction in inflammation. Sometimes you can give oral prednisolone, but just simply non-steroidal anti-inflammatory drugs like ibuprofen, Nurofen. Sodium diclofenac is very powerful, but of course, even paracetamol given orally or intravenously, if it's oral, 1 gram can be given an hour before. So sometimes if we are doing a very long procedure, a long implant procedure, a long surgical wisdom tooth case, or bilateral wisdom teeth, we ask the patient to take 1 gram of paracetamol and between 600 to 800 milligrams oral ibuprofen. Now, the reason you need a high dose is because of low doses of these medicaments don't really do much. So it has to be the correct amount, because a lot of it's going to be broken down by the body, because it's looked at as a foreign body. The body doesn't like it. So if you give it in a high amount, a high dosage, it then means a higher amount is available. The bioavailability increases, which goes to the target organ, which is, of course, the brain, which modulates and regulates the systemic feeling of pain. And then, of course, locally, we give the local anesthesia to mitigate for local pain. So this is a technique I use. This is a case I was doing the other day. So I gave pre-op analgesics. I don't give any intravenous ibuprofen or Nurofen. You can get quite profound sometimes allergic reactions. So I give the patient either 1,000 milligrams of oral paracetamol, but because I can give it intravenously, I put it up in a drip, and this is for a long surgical case, maybe 3, 4, 5 hours implant surgery, and giving 1,000 milligrams, which is equal to 2 tablets of paracetamol, is almost like giving the patient morphine. It's very profound, and we give this in a small drip form, so it's entering the system and working. It bypasses the body system to break it down, and it has 100% bioavailability, meaning 100% of it goes to the target organ that we need it to go on. I also use fentanyl. So fentanyl is a potent opioid, and this, when I mix it with my, for example, midazolam, because they work synergistically, meaning working together, it reduces the amount of sedative I need, which is good for the patient. They're less drowsy afterwards. Their recovery is much faster. But there are other forms. So fentanyl, it's not rapid. It takes about 4 to 5 minutes, but it has a longer half-life. It takes a bit longer to come out of the system. Whereas something like Rapifen, alfentanil, works in has a much shorter half-life, and you can give, for example, 100 micrograms up to 1,000 micrograms during the procedure, and it's a very, very strong opioid analgesic, as opposed to a sedative, being a sedative and not having any analgesic properties. So this would be a technique that I would use with my midazolam intravenously, fentanyl, and then we can give intravenous dexamethasone to help with postoperative reduction in swelling, inflammation, and this can be given again in vials of between 3.3 to 8 milligrams. You can, of course, give this as a loading dose on the day after the surgery as a tablet, so between 8 milligrams the first dose, and then we go for a reducing dose over the next 4 to 5 days. So first day 8 milligrams, second day 6 milligrams, third day 4 milligrams, 2 milligrams, like that. So this is a technique I use all the time when I sedate my cases, or I'm sedating for my specialist colleagues doing oral surgery or more complex dental procedures. Like I said, giving something orally, effervescent is very good. Effervescent basically means if you crush the tablet. So you can get 600 milligrams of effervescent ibuprofen. And I remember our protocol in the King's College Hospital, for every patient that attended the acute dental center who was in pain, the nurses would give this to them while they were in the waiting room, because they usually had to wait about an hour. And we usually found in 90% of cases, once the patient had this, when they came to see us for the dental treatment, their pain was reduced by at least 80%. That's quite significant. So when we then gave the local anesthesia for whatever the treatment was, whether it was extirpating the nerve, the pulp, or extractions, we found it much more profound, the level of anesthetic that the patient got. Again, if the patients have tablets and you don't have the effervescent or the powder form, it's very simple. Crush the tablets up, and the patients can take this an hour before they come to you in surgery. But of course, the most ideal way is to give the intravenous paracetamol. But of course, I appreciate that's not a technique that everyone may be able to do. But if there are surgeons or colleagues in the hospital system working there, this is a very useful way of giving a very quick acting an analgesic to assist your local anesthesia. Of course, if there's a lot of breathing, we sometimes give tranexamic acid. You can give this orally, 10 milligrams, just before the procedure. It does come in liquid form, which is a bit harder to get, so we can use the oral form, which is very useful. And of course, local measures for post-operative bleeding, which I'm sure we all know about. Well, that can be a separate lecture by one of our oral surgeons. Post-operative analgesia, of course, if you've done some surgery, non-steroidal anti-inflammatories like ibuprofen combination therapy works much better. It's shown in many clinical studies. Combining ibuprofen or Nurofen with high-dose paracetamol is very, very useful. And it basically has very low risk of side effects and dependency. Diclofenac, sodium diclofenac, Voltarol, either 50 milligrams to 75 milligrams twice daily, again after procedures, more complex surgery, has been proven to be very, very useful post-operatively, because we not only want our patients to be comfortable at the time of surgery, we want them to be comfortable for the coming days, especially the coming 3 to 4 days where naturally swelling is going to occur. This is a natural occurrence for the body system to push all the good cells from the blood into the surgical site where it will become a bit swollen. So if we can use combination techniques for post-operative analgesia, it really, again, makes the post-operative healing and comfort for our patients much more profound. And these are very common techniques that we utilize and can be utilized in any clinical setting. Again, advanced techniques. So for example, here on the right-hand side, my colleague had a patient who had severe anxiety. He was a special care patient, but this was done in general practice. So I had the inhalation relative analgesia, worked very well with him, made him very calm. He didn't need a lot of anesthetic, which he usually needs without this technique. So very comfortable for the patient, very comfortable for the dentist. Of course, we have specially trained nurses that assist us in this procedure and monitoring. And on the left-hand side, this is a specialist prosthodontist doing some quite complex surgery at the Royal London Hospital. And we assist them in the cases that we do by giving intravenous opioids and sedatives. And ultimately, the patients don't remember a lot, which is beneficial. There are some drawbacks for long-term rehabilitation, but generally, the patient was having a lot of teeth removed, a lot of implant surgery, and we can tailor our doses to make it effective, to give sufficient analgesia, sedative, and of course, then the dentist giving sufficient local anesthetic, because it doesn't matter how much intravenous medicaments we give, sedatives, opioids, if the patient doesn't have proficient local anesthetic, they will be in pain, and we can keep giving more and more and more sedatives. They'll just make the patient more agitated. And hence, just at the beginning, when I stated proficient and sufficient local anesthesia with enough time is actually the cornerstone to having a comfortable procedure for our patient and a comfortable outcome. And they'll feel very happy with you as the dentist that you haven't basically given them more pain or pain that they didn't really need, because we have all these techniques which are used globally and can be used definitely with the right training or training program by our colleagues in Afghanistan. So I know it's been a bit of a whirlwind tour. I don't expect anyone to be a sedationist or to be giving intravenous opioids at this stage, but hopefully in the future with colleagues that we have on our team, specialists, Dr. Hamza, consultant in special care, of course, Dr. Armana dealing with children, and multiple specialist endodontists. They'll have different takes on things, but this is sort of more of a whirlwind tour just to give people an idea of the different armamentarium and how we can utilize these techniques to assist our patients. So I think we can open up the floor to questions, unless there are any questions that have come up.
So there have been no questions in the chat groups, either on YouTube or on Zoom, but we're very welcome for anybody to pop their hand up. And I think that's what we did at the end of the last session when there were some questions. So if anybody wants to ask a question, I can unmute you. You just need to let me know that you would like to ask a question. Either you can send a message in the chat, or you can use the raise hand function. For those who are not used to using Zoom, at the bottom of your screen, if you logged in on a laptop, it comes up as raise hand. If you're logged in on your phone, it will come up as reactions. Then you have to go into reactions, then find raise hand. Any reaction, even if it's a thumbs up, and I'll give you the opportunity to unmute. Now, so we'll give everybody a few moments to do that. What I'm going to do in the meantime is I'm just going to get my screen up to share and prepare for the next session, which I'm going to be streaming on a different link on YouTube. So I'll just get that ready whilst we're waiting to see if anybody's got any questions.
And do you know how many sort of attendees we've had at this? I can't.
So I think looking at the different types of names we've had people joining and then leaving. So there may be connection issues. And last time we had the same sort of difficulty. We've had at least 20 different names at different times. Even though the participant numbers have gone up and down, I can't tell through YouTube what's been on there.
Okay, sure. Okay, people watching it in there.
Okay, so it's similar to last time as well. Okay, so I am going to share this one, hopefully. Okay, so are you seeing this screen at the moment?
Yes.
Except it says we're waiting. Okay, so this has got the Dean Partners program. What I'm going to do is I'm just going to create a separate link because it might be easier for people to have the live stream to look back on later. Okay, it doesn't seem to be allowing me to do a separate live stream link. So that's fine. Let me just quickly check that it is actually still streaming on YouTube. Sorry, give me one moment. Yeah, it is actually still streaming. It's just, I can't seem to find the function for it. Okay, so we move on to the next section. Dr. Munir, thank you very much for your time going through local anesthesia. I'm sure there may be some follow-up questions via WhatsApp, which did happen last time as people caught up on the recordings, and we'll forward that to you. And we really appreciate your expertise and your time sharing that with us. Thank you very much. Jazakallah khair.
Okay, Jazakallah. Assalamu alaikum.
Walaikum salam. Okay, so this final section, apologies, I couldn't create a separate link for this. It's to go through the partners program. So we'll just explain again. So what is it? We explained this on the last webinar, but it's using patient advice requests, which is the first PAR in partners, and it's using that for teaching, networking, and education. So let's break it down a little bit more. What types of patients? These should be current patients that you are treating rather than previous cases. The reason we want to do that is because we have two aims from the Partners Program. One of them is education, training, networking. The other one is actually to be able to deliver some expert advice to patients who are undergoing treatment and impact somebody on the other side, affect care. If we're talking about theoretical cases or cases that have already been finished, then there's not that direct benefit to the patient, which is why we want to focus on current patients. Having said that, if you don't have a current patient case to submit and you've got a previous one that you want to, then you can do that as well. But please let us know it's a previous one. So when we're doing our own evaluations and monitoring, we can highlight it as a previous patient case. We are hoping to assess the impact to patients from this, and that's why we need to know that difference. So is a current patient that you're treating, and it could be that you don't actually have a question. You just want peer review. Now, the word peer review is something we use a lot in the UK. It means you ask other people who have a dental background similar or slightly different to your own, to say what is their opinion on what you're doing. And through that, you start to get a temperature sense or a gauge about whether your treatment planning is in line with what other people in your region, other dentists in your region, and with your access to materials and things are doing similar things, or whether you're an outlier and you're doing something very different to what other people are doing around you. So peer review helps with that. Where it also helps is when you're comparing what you're doing with people who don't have the same background, materials, experience, and skills and training availability. Because then you're comparing, well, why are we so different? So an example to that would be if I wanted to compare how UK dentists treatment plan caries in a child compared to American dentists. There's actually a massive difference. And then we can look at the reasons why, and we might actually find a lot of it is due to the payment systems and the fact that we have universal healthcare to all children that is free, but that does mean that we really look to see, is there a benefit to the patient and what's the cost to the NHS by doing this? Is it worth doing this treatment? Whereas in somewhere like America, where it's insurance-based care, their differences might be because they've got insurance paying, and quite frankly, dentists get paid more when they do more treatment. So these are the reasons why you do peer review. You then look at why there's a difference, and you make a sort of decision about whether you want to change what you're doing based on what everybody else is saying that they do, which might be different or similar. So that's one reason, peer review. The other reason might be because you actually want advice. You're not sure what to do next, and you want somebody who's, got specialist skills or a consultant in this area to give you advice on that. And that's the main reason why it's used in the UK. And it's so that we can access consultant advice. And then you also want to compare, and that's similar to peer review as well. It's just more specific that you want to compare to the UK dentistry and pick out where are the differences and why. So the next part of the partners acronym is for teaching. And we've explained previously that you have lecture-based teaching like this, which is theory-based, and then you try to apply it in your own scenarios at work. But sometimes that's more or less successful, depending on your ability to translate what you learnt in theory into something practical. But with problem-based learning, you've actually got a problem in front of you that you have to solve, and immediately what you're learning, you're applying to something. So the learning, we feel, tends to be of a higher quality. The other reason is for networking. Through this process, you will get to know each other. You'll become familiar with each other's styles of working, your abilities to do dentistry, but also what different settings you work in. You'll start to collaborate more because now you know each other and you're networking in your regions. And you might say, actually, I have this patient who needs an implant, and I saw this dentist who submitted a case where he's doing implants, and he can do something like this because I saw a case like that. Or I saw this sister who submitted a case about a child she was treating, and she did some really good work that I think I would like to send a patient there to her. Or you will create your own local collaborations where you might set up a study group because you now know who's got different skills. Everybody has different strengths that you want to try to pull together. And even internationally, we can use that because we'll be able to network and say, okay, we want to provide, we really want to provide some equipment and materials and supplies to our brothers and sisters in Afghanistan, especially after our visit. But we need to work out through our networking what that resource gap is, where it needs to go, and who are the right people who can help us to get that into those places. It's only through these discussions that we're going to get to know each other. And then coming back again, reinforcing the teaching, it's for education reasons. But education's not limited to teaching and to clinical topics. So I did want this part to be a bit interactive, and I was going to ask you what you think you might learn through these cases that's not purely clinical. But I can see people are having connection issues. I can see there's also a question that got submitted just before Dr. Munir left, which was, what is the average dose of sedative medicine in children for surgery? So I will come back to that question at the end. But has anybody got any comments or points they want to share on this particular question right now, which is what we might learn through these cases that's not restricted to clinical dentistry. I'm just going to check YouTube, see if there's any comments on there. Does anybody want to try to unmute or request to unmute or send a message? See if there's any. Okay, and I can't see any comments on YouTube, so I'm going to go ahead and just fill in the gaps there. And the kinds of learnings you might have is about interactions and management. And so an example might be that we recommend that, or, you know, there's a question that involves sedative medicine for children, like the question that's been posted in the group. We won't simply answer that question. Let's take that as an example, because what is the average dose of sedative medicine in children? I will actually come back with 5 more questions. I'll say, what are the age of the children? What is the purpose of the sedation? Is it conscious sedation, or are you talking about general anesthesia? What is the medicine? Because that's going to affect the dose. And what routes are you delivering it through? Is it intranasal? Is it intravenous? Is it oral? And that's going to affect your dose. Then we'll say, well, you need to know the weight of the child, because often the dose is not about the age of the child, it's to do with the weight. In the UK, there's different levels of sedative complexities. We have advanced sedation when you're using what we call polypharmacy, which means lots of medicines, or using more than one drug. And if you're doing it on a child under the age of 12, and it's not just inhalation sedation, which is breathed in laughing gas, then it would be something called advanced. That tends to be led by anaesthetists. So it's not a straightforward question at all, that one, and we need a lot more context to it. Once we've got that context, I would actually just ask, okay, tell me about your service. What do you want to do? What are you trying to achieve? What equipment do you have? What facilities do you have? So I'm not giving you just a clinical answer there. I'm going to be giving you some management tips. We'll be going through the safety of how to deliver sedation. We'll be discussing what equipment, facilities you need, what training you need, and talking about how to set up a service safely. That's something called clinical governance. That kind of training about the policies and evidence and processes to delivering care doesn't come under clinical dentistry, and we're not trained it as part of our undergraduate careers, but it's really important when you want to set up services, especially if you want to make an impact beyond your own service and do something for the local community or for Afghanistan in general. So let's move on to the next question. I hope that answered your question, iPhone user, but I'll also forward it to Munir if you can, Dr. Munir, if you can reply back on the WhatsApp group with more information, like I'd said, what age children, what level of sedation, what weights, which drug, which route, we can then try and get you some answers for that. Okay, so the next slide, we're talking about how do you submit a case? So today we've sent some resources on the WhatsApp groups, and one of them is a guide on how to submit a case and some simple steps. So the first thing you're going to do is you need to discuss that you want to submit the case with the patient, because you need to ask their permission to share their details. That is a universal principle in dentistry across the world. And even if there isn't a dental regulator in Afghanistan as strict as the one that we've got in the UK, where we will be struck off if we shared anything to do with a patient, even if it was anonymized without their consent, you should still stick to those principles, because those are the ethics of dentistry. And ethics means what's right, what's wrong, what's moral. So that's the first stage. Discuss it with your patient and agree with them. And if you look through the simple guide, there's some bullet points on what you should cover in those discussions. The second thing is it's very hard to discuss a case based on text. We do need x-rays and we do need some pictures, but those pictures are going to be what's relevant to the case. So for an endodontic case, you might get away with just a picture of the tooth, and sometimes you might get away with just an x-ray. But generally, you want to have a picture of the tooth in question, the teeth either side, so that section of the arch. And definitely in pediatric dentistry or for orthodontics, we need the whole patient. We need to look at the patient as a whole. So we need arch photos, that's the lower arch, so we can see the alignment of teeth, which teeth are in there. And we need the pictures in occlusion, so we know whether they've got their maxilla or top jaw too far ahead or behind. And the same with their mandible, if it's in the right position or if it's biting ahead of the top teeth. So we call that class 2, class 3, or normal occlusion. And we can go through that in future lectures when we talk about assessments and different disciplines a bit more. Okay, so once you've got the right images, then you need to fill in the partner's PowerPoint template. And we're going to go through that in the presentation as well. That's been shared on the WhatsApp group. And I'll show you an example towards the end of this sort of session where we explain what that is. And once you've put that together, you just post the PowerPoint on the WhatsApp case-based discussion channel. And we have an admin team. We will organize it. We will work out which specialist you need to have answer that question for you. We have got specialists from oral medicine, endodontics, prosthodontics. We've got an orthodontic specialist who's advising special care and pediatrics and maxillofacial surgery, and an oral surgeon as well. So hopefully whatever question you ask, we can try and get you the answer for you. Once we've allocated an advisor for that, they will have a look at the case and they will then send you an explanation. It will be in English, and if there's a difficulty understanding that, then this is where your peer-to-peer network works. This is why we're called Dean, because it's about education and networking. And this is where, by supporting each other, you actually build professional networks. And one of the dentists who does understand English well will be able to translate that for you. You just need to reach out and let us know that that needs to happen. And we'll also write up the summary of the case and then put that on the PowerPoint as an extra slide and send it back to you. But all of those stages, if you're confused or you're not sure what to do, then we are here to help. So send a message on one of the chats, and we've got 4 or 5 different admin dentists who are there just to help you with that. Okay, so what was the next question we were going to look at? If I can change my slide. How do you get a response? So I've explained already, we'll send a voice note or a recording, and then we'll summarize the advice in writing and we'll add it to a slide on the screen for you. And then how can you ask questions? So if you're not sure about what's happening or you didn't understand the response, then we want to be as interactive as possible, and we are not limiting how you can contact us. You can send a voice note on WhatsApp, you can send a message on WhatsApp, and you can also send an email. Whichever method suits you, please share it. What I would ask is don't be shy and please share it on one of the open chat groups. If you want to share it on the sisters only one or the brothers only one, that's fine. Or you can share it on the case-based discussion channel. The more you share your question, the more you'll find that you weren't the only one with that question. And actually, there'll be at least 5 or 10 people who will be saying, phew, thank goodness they asked that question, because I had the same question too, but I was too shy to ask it. So we have produced some resources to help you. There's an English version of a simple guide to using the Partners Program, and then that's been translated into Dari for you as well. We've also got a guide on how to take pictures and a model consent form, which we'll be sharing soon. It's all ready. We're just trying to limit the amount of information we throw at you in one go. You can find all of these on the WhatsApp groups. If anybody isn't on the WhatsApp group and is watching this on YouTube and needs to find how to do that, then please, if you're in Kabul, speak to the Rais or the Dean of the Stomatology Hospital or the Kabul Medical University, Medical Sciences University, or you can send a message as a comment on the YouTube channel. And as soon as I notice that, I'll try and get in touch with you. So hopefully that will help. Then we've created an example case for you. One of them, so I've shown you the messages of what they look like on YouTube, and I've shown the example of a PowerPoint that somebody might submit, and then the example of what the advice might look like as it's come back. So what I'm going to do now is just share the example and go through that and make sure I am sharing the right screen. Okay, so you should be seeing this example one. I'm going to play it from the beginning and just make sure that's come up. So yeah, I can see on YouTube that it's the right screen sharing. So this is the example case. And if you look at the template, it's empty. I've just made up a name to put this together. Now, this first page is really important for us because we will be keeping a catalogue of all the cases. And when, especially this consent part, if somebody has said yes to this part, that they're, given the patient's given consent to discuss on WhatsApp, but then they've said no to discussing it on an online video, we won't discuss it further or use it as an example in any of the monthly teachings. So we'd like to know the dentist's name here because we need to know who to speak to about it, if there's any follow-on questions, things like that. And we just want the patient's initials. We don't want any more identifiable information. It needs to stay anonymous, but you need to be able to track back which patient it related to. And we need to know the patient's age for obvious reasons, because sometimes age matters, especially in children, in terms of what's going to happen in their growth and development. And it'd be helpful to know their gender as well, because as we know, boys and girls grow differently. And especially when we're considering trauma or the development of the teeth and orthodontics, the times for treatment will be different for both. And then try and guess what specialty the clinical query relates to. If we then assess it and say, actually, I think we need more than one specialty on here. So this one, the example, it said pediatric dentistry. I actually got an orthodontist involved as well. And this is an example that's a real example. It's submitted through the UK advice and guidance system that we have, which is a written one. And I spoke to the family and I got permission to share it with the Afghani dentists and to use it on the YouTube example as well. And I've made up the name of the dentist. The dentist's name wasn't Fatima Bukhari. Okay, but I want you to save the file with the dentist's name, the patient's initials, the specialty, and then the date that you're submitting it. So here's another example at the bottom. We've said it's Omar Farouk and TH, just to show you different examples, but that should be the file name. Okay, then the next slide talks about the relevant history. And in the beginning, you might want to make this as detailed as possible so that we're not missing information. But over time, you will start to know what to mention and what has to be in here. So the most important things are here. So in this example, this was a child. We know she's 12. She initially attended complaining that she needed a filling on the upper left 6, and she was a waiting list for treatment under GA. Now, as you've noticed through today, we use lots of acronyms in dentistry in the UK. So if we do use one that you're not aware of and you don't know what we're talking about, please be brave and just message us and say, what is GA? Because the whole of this case relies on knowing what GA is. And we are so bad at using acronyms that we constantly need to be reminded about it. So a GA stands for a general anesthetic. And this gives you an example of how bad the situation is. This child waited for 18 months to get to the top of the waiting list. Now they were at the top of the waiting list and the situation's changed. They no longer need a filling on the upper left 6. The upper left 6 is now causing pain and it's spontaneous and it's caused loss of sleep. That was really important information for the dentist to share because it shows us that we're dealing with a tooth that's got irreversible pulpitis. It will need to have a root canal treatment or an extraction. So I'm starting to think down that line. This child, their medical history, they have autism. Otherwise, they're medically fit and well. And we know autism is something that is a behavioral condition. It's about it's a neuro disability. It's not necessarily classed as a medical problem. Their cardiovascular, breathing, and different systems in their bodies actually work well, but it's how they process information and how that affects their behavioral needs. So sometimes we put autism in medical history, sometimes we talk about it in social history. Now in pediatrics, we always want to know about social history. And parents sometimes, they get quite defensive and they're saying, well, why are you asking us this question? Because how is that relevant to the teeth? And in this situation, they disclosed when we've asked who lives in the house, what are the other children's needs, that this child has an older brother who's non-verbal autistic. This means that her older brother can't speak at all and really struggles with communication. And the brother lives and she lives with both her parents and the brother at home. This is important because now we know that she's going to have some difficulty when they do need to attend for a general anesthetic, because one parent's got to stay taking care of the other brother. So there might be some issues on them being able to attend, and how can we change our care to accommodate that? They've then shared that this child attends a mainstream school. So that means that they don't need to go to a special school where they've got extra teachers, which is for children who have severe difficulties in learning and communication. So this child, even though they have autism, they can cope with most normal environments, and they're managing to get along with things to be in the same classroom as neurotypical patients. But she needs some additional support, and she's very nervous and she's very shy. Her dental history, she's previously been able to cope with Hall crowns, which means it doesn't involve drilling, it doesn't involve local anesthetic. It's a very simple procedure where the crowns have been pushed onto her baby teeth. And she's also coped with an extraction with laughing gas under inhalation sedation, but she can't tolerate a drill. Water in her mouth or loud sounds will make her upset, and she needs a more profound level of sedation. Profound means a heavier level, where she's quite drowsy, or a general anesthetic so that she can have treatment. And then she's not going to cope with orthodontic treatment either. And that's something people would say, well, why have you put that in? It's not even an orthodontic question. But you'll see later in the case that there is actually an orthodontic issue here, and knowing that she's not going to be able to cope with treatment means I'm not going to give advice about things that require orthodontic treatment. I'm going to try to limit it to something the patient can actually access and cope with. We want to have real life dentistry. There's no point giving fancy treatment plans that can't be delivered. So in her examination, they've said that she's got a class 1 skeletal base. That means that her front top teeth overlap her bottom front teeth, and not by an increased amount. Her jaws are in a good relationship, as you'd expect, between the maxilla and the mandible. That's what we mean when we say class 1, and hopefully you're using similar terminology, but please let us know if we use terminology that you're not aware of. The other point that they've highlighted for us is that they're potentially going to have an impacted tooth in the upper right quadrant. And that's what URQ means. That's, again, dental shorthand for UK dentists to mean upper right quadrant. And she's got molar incisal hypomineralization. And whenever I submit a case for you to discuss, there's probably going to be an element of MIH in it, because it's my bread and butter as a pediatric dentist in the UK. Lower right 6 has some post-eruptive breakdown, and it's really good that I'm deliberately using the term post-eruptive breakdown here. People would say cavity because there's a hole in the tooth, but by saying post-eruptive breakdown, you're being very specific and pointing to the fact that the tooth broke down not because of dental caries, but because of the MIH. So we call it breakdown after it erupted into the mouth, which is not related to diet or hygiene factors. That post-eruptive breakdown is on the disto-occlusal and the lingual surfaces. So they've explained what I can't see in the picture as well. What I can see in the picture, they've just left in there. And what's really nice here is they've explained on the upper arch images that it says in reflection. That's really important when you're doing virtual advice and guidance. If I didn't have that written in there, I might not have picked up on the edges of the mirror that you can see on this slide as a clue that I'm looking at a reflection, which means that the left is now on the left, whereas we know dentally it would actually be on the right, and the right is on the right. So I won't make a mistake when I'm giving advice in orientating myself. And if we look at this picture, we count the teeth. You always try and make sure and orientate yourself. So we've got 1, 1, 2, 2, see an unerupted 3, but it looks to me like there's enough space for that to just come through, and I can see the tip of it pushing itself out in the line of the arch. We've got a 4, we've got an E, which has got a crown. We've got a 4, and then there doesn't seem to be much space here between the 4 and the 6. And then you've got a 6 here, which is not great. You can't see it in this picture, but you can see enough to see it's got a cavity. And if you look even better, closer at that picture, you can see it hasn't got the typical shape of a carious cavity. We call this an atypical cavity, which is a clue to the fact it was caused by MIH, because the breakdown is on the surfaces that had hypomineralization, and that doesn't follow the normal pattern of caries. Caries normally comes in the interproximal surfaces or the occlusal surfaces or the buccal pit or palatal pits, places where plaque sit and get trapped. So that's another reason why that's important to note. So I'm now talking through to you what I'm seeing on these x-rays. And this is what the advisor's doing as they look at this. So then the next slide, the dentist has put in the picture of the lower arch. It's very blurry, but why have I asked for this? I'm actually not asking to look at the condition of the teeth. I want to see the alignment of the arch, and that is well described in this picture. I can see that they've got lower labial crowding, but I'm happy they've got enough teeth, enough space for their premolars to come through, and I can just about see the 6s in there. This one, they've said the image has been rotated, not electronically reflected, and is taken in an image. That's probably a typo. So I'm not sure what that is. The right side of the image is the right side of the mouth. That's the important thing. So this is the lower left 6. This is the lower right 6. And actually, you can just about see a shadow on the lingual surface there, which might be an atypical cavity, which is caused by post-eruptive breakdown. And they've said this is the best image they could get because the compliance was poor. And remember, we're talking about an autistic child here. Okay, so now let's go to the next screen. We've got the radiographs. Now, they've said this is the most recent OPG, 17th of January 2025. And they're going to write here what they want to draw my attention to. So it says an OPG, and it says that this child has third molars developing in each quadrant. So, yep, we can see the third molars developing in each quadrant. And a retained primary incisor. I don't think there is a retained primary incisor. I think they've looked at this x-ray and they think this tooth is retained because it's small. But if we go back to the pictures, which is this one, there's no primary incisor there. So when I'm giving my advice, I might highlight that to them that actually I don't think there is a retained primary incisor, and they might want to check the dates with the images of the mouth and then be sure about that. And they've said there's potential crowding in the upper left quadrant. So this is the upper left quadrant because the left's there, but this is actually the right. So again, I'm looking at this thinking, is there a typo here as well? Because that's the upper right, and that's where there's potential crowding. Here, there is some potential crowding, but there's enough space for the teeth to erupt. Okay, then they've got their next slide, and this is taken previous OPG for extra information. And over here, there's no date, right? So as an advisor, I would be messaging this dentist back and I would say, can you tell me what date this was taken? I can see this some time has gone because you can barely see the crypts of the third molars developing here. But what's really interesting is if you look at the level of the 7 in these quadrants, the 7th tooth compared to the 6th, and then you go back to the previous slide, that level is the same, but the root development is much more advanced. So there's been no eruption of this second molar in the time in between. Now, I'll save you the suspense. I did message the dentist and say, look, there was no date on the second x-ray. Can you tell me when it was taken? And then I asked about this retained primary incisor and said, I don't think there is a retained primary incisor. I think what you're seeing there is where this root is not in the full focal trough, so it looks shorter and it might look like a primary incisor, but it's not, it is the permanent one. And then I asked about their lefts and their rights. Okay, so managed to correct all those typos. Now I'm going to look at the most recent radiograph as an advisor, and I'm going to go through in order. And I always start by counting the teeth. So I go 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8, and so on. And I will do that no matter how many times I have looking at x-rays and no matter how much of an expert I think I am, because the one time I won't do it, I will miss a missing tooth or something ectopic, which means it's out of position. And I can see here that this premolar looks stacked, but there is space because there's an E there, and she's got some problems with this tooth, so I'm not worried about the fact that that's a little bit crowded. I know that this tooth is likely going to need to come out because it's got irreversible pulpitis, it's got caries right deep into the pulp, and this child can't cope with treatment except under sedation or a general anaesthetic. And in the UK, we will not offer root canal treatment under sedation. We will only take teeth out if they need IV sedation or a general anaesthetic. There is a caveat to that. If there is hypodontia or something very significant for this child, that means we really need to keep this tooth. Okay, so looking at this x-ray, I can say, right, that needs to go. I can see if I take that tooth out, that premolar has got the potential to erupt, but not while that E is there. It's got a long enough root for the E to be present for a little bit too long, and then the 7, well, not in this case, but in a different child that doesn't have an eruption problem, the 7 might come forward and then take that space. Then you still end up with the 5 being crowded. So if you want to encourage that 5 to disimpact, you also need to take the E as well, so that can just drop down. In this quadrant, remember, this is a child who can't cope with orthodontics, okay? They have got an impacted tooth here. There is no way that that premolar can erupt in the arch, which means if we do nothing, this premolar is going to erupt either in the palate or the cheek, or it will stay impacted and then it could cause resorption of the roots either side, or more likely what we see quite often is it becomes cystic and you get a cyst around the unerupted tooth. So we want to do something about this. And the dentist, now I've got my own thoughts about these x-rays, but let's see, what was the dentist's questions before I start jumping ahead? The dentist is going to give me some relevant background information here that's going to help me to whittle down the options that they've got. So they're telling me they're not going to tolerate treatment under local anesthetic unless it's very simple. She's not going to cope with orthodontic treatment in the future. They are highlighting, in case I don't see it, what their concerns are and pointing me towards their concern. Upper right 5 is going to be impacted. Upper left 6 has to come out. So I don't have to tell them these options. They already know that part. Now, this dentist says, well, they've got wisdom teeth developing. They think this is a good case for elective extraction. And those people on the Brothers WhatsApp chat will remember that I shared the UK policy on elective extractions for molars. Then it says if you've got third molars, then and unerupted second molars, then this is a good timing to consider that. So that's why this dentist is asking, is this child a candidate to take out the lower right 6 and the upper right 6 at the same time as having a GA to take out the upper left 6, because the second molar is still unerupted. So they're saying they want to take out the upper right 6 because the upper right 5 is impacted. They want to take out the lower right 6 because it's broken down and it needs a restoration, which is going to be hard for this patient to cope with under normal local anesthetic. But now let's go back to this x-ray. If this was the case, that this tooth had erupted further in the gap between these two x-rays were taken, that would be a good plan, because this child cannot cope with the treatment burden of maintaining a restoration when they can't tolerate a drill, and she is autistic. It's not something that's going to change by becoming more confident. So if she was in that treatment window where taking this tooth out means she's got two healthy teeth that will move forward because of the pressure of the wisdom tooth, and she would end up with her 7 and 5 in direct contact, almost effectively not missing a tooth and still having two functional molars in this quadrant, that would be a good outcome. Similarly, in the upper arch, if we were to take out this molar and let the premolar come through, then she's still got two molars that would come forward. However, in this case, remember what I said to note about these 7s not erupting. This is a very rare case of something that we call primary failure of eruption. When you have teeth that don't erupt, there's two causes. It's either mechanical failure of eruption or it's primary failure of eruption. Mechanical failure of eruption is something we're all very familiar with. And that's what would happen if this premolar stayed impacted. It couldn't physically get through because there's not enough space or there's something getting in the way. We see that a lot with what we call impacted 6s, impacting on the back surface of the E's. We see impacted canines. We see ectopic teeth that are so out of position that they physically can't erupt. We see that with supernumeraries in the anterior palate that stop the adult permanent front teeth from coming down. Those are all mechanical failures of eruption. Primary failure of eruption is something genetic. It's where the processes that cause eruption, which are still not fully known to us, don't work properly. And it can happen with any tooth in the dental chain. But then once that tooth is affected, all the teeth behind it in the chain are also affected. So if you had primary failure of eruption of a 6, which is the first permanent molar, we in the UK, we call these numbers, we say this is A6. I don't know if you do that in Afghanistan, but you will get used to us all calling this A6 and A7 and A8 like they're nouns. So if it happened that this 6 didn't erupt, then that would be primary failure of eruption. And in that quadrant, all of the molars wouldn't erupt. There has been some research now which has managed to pinpoint some genes involved in this and some genetic testing that can highlight the risk of it, especially if there's somebody else in the family that's had a similar problem. When I have seen it, it's normally in one quadrant, sometimes two. It's rare to find all 4 quadrants affected. So what I did in this case is I then took it to my orthodontic colleague and I said, I'd like to confer with you. I think this is primary failure of eruption. What do you think? In order to diagnose primary failure of eruption, we need sequential OPG radiographs, and we need them over at least 2 years. There was a 2.5-year gap, actually, if I remember correctly, between this X-ray and that X-ray, and there's been 0 eruption of the 7s, and the roots are developing downwards towards the lower border of the mandible. So we were able to confidently diagnose that this is primary failure of eruption. So now, bearing that in mind, had a conversation with the parents, and I said, even though this is a really tricky restoration, and to restore it, there's actually gingival overgrowth over this area, this child's going to need electrosurgery under general anesthetic to cut away the gum and cauterize it so it's not bleeding, so I can get a good restoration because I won't get good moisture control without that. And we'll just have to accept that she'll need sedation whenever she needs maintenance of that. In this arch, we would have taken the 6 if she didn't have primary failure of eruption so that the premolar, the 5, could come through. However, in this case, we know she's not going to get the 7 and the 8 coming forward into this space. And it's better to have a molar to bite on and lose a premolar. So instead, what the orthodontists recommended is if we take the premolar out, then the 5 and the 3 can both pop through and she'll still have 1 molar. And then that will resolve the impacted tooth in this area. And over here, if we take the 6 and the E, then the 5 can come through. We know she won't be left with a molar in this area. There's nothing we can do about that because the 7 and 8, you can never bring it through. You cannot do exposure and bonding. So that might be a question that would be a follow-up on the WhatsApp group. Somebody doing orthodontics will say, well, can't you do expose and bonds of these teeth? No. When it's primary failure eruption, even that doesn't work. We cannot pull these teeth into the mouth. It just doesn't seem to work. What we haven't tested and what there hasn't been research on is auto transplants. and whether you can extract the unerupted tooth and then suture it into position, which means stitch it into position in an erupted position, and then hope that it ankyloses into the bone. That is something that's a realm of research. But definitely we know that if you expose and bond these teeth, they do not come in. And so that is the advice for this patient. And that shows you a little bit about what goes on in the background. It would take me about 20 minutes once I've seen a case that's been submitted on WhatsApp to look at it, consider it, make my plan. And then, like you've seen on the example that we've shared, I would send a screen recording of me talking over the presentation, giving my advice and pointing things out to the dentist. We'd send that, you would review it. If you've got further questions, you'd come back. And then hopefully, because everybody on that WhatsApp group is watching this case, you'd now start to ask questions. And I hope that from tonight, there'll be a flurry of questions asking about primary failure eruption. Somebody's going to ask me to post the paper. And when somebody does, then I will share it. But that is my test to see if anybody actually stayed right till the end to listen to this recording. Thank you very much. We will end the session there, and you've got access to the recording to listen to in your own time. And we're looking forward to your questions on